Thank you all for being here. My name is Joan Stauffer, and I'm Product Marketing Director at Iridex. And it is very much my pleasure and my honor to introduce Professor Okhoshi from St. Luke's, and she's here to present on MicroPulse for DME. Professor Okhoshi, thank you for being here, and the podium is all yours. Thank you.
Thank you. My name is Kishiko Ohkoshi. I came from Japan. I have been using MicroPulse laser for more than 10 years. I'd like to thank to the Iridex company to provide the opportunity to give a presentation at Iridex Speakers Forum. Thank you. I'd like to begin by briefly describing the paradigm shift that has taken place in the field of retinal laser therapy for the treatment of diabetic microedema. Since ETDRS reported the efficacy of laser treatment for diabetic macular edema, many treatments have been reported to control the DME. In 2014, anti-VEGF treatment was approved and started to be used for DME treatment in Japan. There is a lot of evidences that show anti-VEGF treatment is superior to laser treatment alone. The RCLNet showed that intravitreal ranibizumab injection significantly improved visual acuity compared to laser treatment alone. However, 31% of the patients required rescue laser treatment within one year. The RCLNet Protocol T also showed the efficacy of 3 types of anti-VEGF drugs. However, surprisingly, in this study, the laser treatment was given to 41% of patients in the aflibercept group, 64% in the bevacizumab group, and 52% in the ranibizumab group. Therefore, laser treatment is very important for controlling macular edema and necessary for successful anti-VEGF treatment. Although studies have shown the efficacy of the anti-VEGF treatment, it is worth noting that anti-VEGF injection is invasive and has its disadvantages. For instance, repeated injection lead to higher cost and an increased risk of endophthalmitis. Moreover, anti-VEGF drugs have been shown to be ineffective in certain cases. It has been reported that combination therapy using anti-VEGF and laser treatment decreased the number of injections for DME patients. Therefore, laser treatment is expected to save money and lessen the financial burden on patients. However, since conventional laser treatment is destructive, most ophthalmologists are concerned about potential risk of scarring on the retina. Now, we do not have to be concerned about unfavorable laser scarring since MicroPulse laser is available. These are fundoscopic images of patients treated with MicroPulse laser. The laser ablation site is hardly detectable with focal laser and completely undetectable using grid laser. In this seminar, I'll show you how MicroPulse laser has turned laser photocoagulation into a safe treatment modality. I will also explain the mechanisms underlying subthreshold invisible non-damaging laser treatment. First, let me explain the concept of subthreshold laser. Conventional laser lead to localized burning on the retina, and the laser site becomes a white spot that is clearly visible. Upon lowering the laser energy, we can reach a level where the laser site becomes barely visible. We refer this setting as the threshold level. Subthreshold laser is defined as a low level of energy at which laser scars are undetectable. Here's an example of a patient who was successfully treated with subthreshold MicroPulse laser. This patient was referred to me with persistent diabetic macular edema, which was unresponsive to anti-VEGF therapy. I applied subthreshold MicroPulse laser using the textile laser confluent to the area that shows diffuse dye leakage. These are images that was taken immediately after and 5 months after laser ablation. The laser application site is not visible and the laser scars is not detectable. After the treatment, macular edema decreased and there was a moderate improvement of visual acuity. A number of reports have shown the efficacy of subthreshold MicroPulse laser. This is a paper that I recently published showing the result of MicroPulse laser treatment in Japanese patients. Visual acuity was maintained and there was a statistically significant decrease in CMT in 1 month after laser treatment. There have been a few reported randomized controlled trials comparing MicroPulse and conventional laser. In 2009, Figueira and co-workers reported that treatment efficacy was equivalent between subthreshold MicroPulse laser photocoagulation and conventional laser photocoagulation using green laser. Moreover, Lavinsky and co-workers reported that high-density MicroPulse laser treatment improved visual acuity and macular thickness was substantially reduced compared to modified ETDRS laser treatment in patients with DME. These findings suggest that clinical performance of subthreshold MicroPulse laser is equivalent to or even superior to conventional laser treatment. So, what is MicroPulse laser and how does it differ from conventional laser? Conventional continuous wave laser provides continuous radiation by stepping on a foot pedal. Retinal temperature rises constantly during the radiation. In contrast, MicroPulse laser provide a train of short intermittent bursts of radiation which minimize the elevation in temperature of the retinal tissue. Retinal temperature rises and falls during ablation and depends on the duty cycle. When the duty cycle is less than 10%, elevation in retinal temperature is limited. With conventional continuous wave laser, heat is conducted to the adjacent tissue, including the photoreceptor and choroid. In contrast with MicroPulse laser, there is a minimal heat conduction to adjacent tissue and ablation is limited to the retinal pigment epithelium. When I started to use MicroPulse laser, I was concerned about structural and functional changes after the use of subthreshold MicroPulse laser. In fact, subthreshold MicroPulse laser ablation does not damage the outer retina. Spectral domain OCT showed that photoreceptor and RPE layers are completely preserved after laser ablation. Moreover, fundus autofluorescence was not detected after laser ablation. These results suggest that subthreshold MicroPulse laser does not affect the structure of outer retina. What about functional changes? These are microperimetry images before and 2 weeks after subthreshold laser ablation. Strikingly, retinal sensitivity improved at the precise area of laser application. We checked 49 spots in a 1 by 1 millimeter square. This slide shows that the photoreceptor cone cell density observed by adapted optics fundus camera had increased after MicroPulse laser. These results suggest that the subthreshold MicroPulse laser did not damage the outer retinal tissue. Now we understand that MicroPulse pulse laser does not cause any clear damage to the retinal tissue. If this is true, what is the mechanism of action? Reduction of macular edema with conventional grid photocoagulation relies on retinal tissue damage. Destruction of RPE and photoreceptor cells, reproliferation of the RPE cells, and increase in the partial oxygen pressures lead to improvement of macular edema. On the other hand, subthreshold MicroPulse laser ablation is a non-destructive procedure, and the RPE and photoreceptor layer are preserved after the ablation. Therefore, the mechanism of treating macular edema without tissue destruction remains unclear, and it may be completely different from that of conventional laser treatment. In order to elucidate the mechanism of action, we constructed an experimental model in vitro in which cultured human RPE cells, ARP19 cells, were irradiated using a diode laser in CW and MicroPulse mode. First, we used continuous wave laser to irradiate the ARP19 cells, and bright field images was captured using a confocal microscope. The white dot circle indicates the laser irradiation site. These are time-lapse images taken during the first 2 hours after irradiation of our ARP19 cells. We can observe the cells gradually changing into a ring-shaped configuration. Sorry. These are time-lapse images taken during the first 2 hours after radiation of ARP19 cells. We can observe the cells gradually changing into a ring-shaped configuration in the peripheral area of the radiated site. We performed a live date assay 2 hours after ablation. The green color has stained living cells, while the red color indicates dead cells. The cells in the central area had died and therefore stained red. There was also a ring-shaped area where cells were alive, but their morphology had somewhat changed. We defined subthreshold photocoagulation as sublethal irradiation in which changes in the cellular structure are found, but there is no cell death. We investigated heat shock protein expression after irradiation MicroPulse laser with sublethal condition. This slide shows HSP17 expression level after the application of 81 shots of sublethal MicroPulse laser. Maximum expression level of HSP17 messenger RNA in the laser irradiation group was reached 3 hours after laser irradiation and momentarily rose to 3 times or more compared to the untreated group. Heat shock protein is a protein that is synthesized under conditions of increased tissue temperature. Elevated HSP elevation in past reports is assumed to play a role in the improvement of macular edema through its protective actions. In particular, they are thought to influence intracellular apoptosis and inflammatory pathways. Therefore, HSP70 elevation is considered to be one of the triggers that activates biomolecules with therapeutic property that lead to the resolution of macular edema after subthreshold MicroPulse laser application. This slide shows a clear difference between MicroPulse and conventional laser. The image on the left shows cells that have undergone MicroPulse laser ablation, in which immunofluorescent signals of HSP70 expression were detected at the laser ablation area. The image on the right shows HSP70 expression after conventional laser treatment. Note the difference. Signals are detected in the entire area after subthreshold MicroPulse laser ablation. In contrast, with continuous wave laser, HSP signals are detected only at the rim area because LP cells are dead in the irradiated central area, suggesting that cells with sublaser damage are located around the laser ablation site, producing HSP. These results suggest that the mechanism underlying MicroPulse laser therapy is linked to the sublaser ablation of cells. HSP70 was expressed and upregulated at the subthreshold MicroPulse ablation site. Interestingly, HSP is also expressed in the area surrounding the subthreshold laser ablation site. Therefore, HSPs may play a role in the reduction of macular edema, not only in the subthreshold MicroPulse laser ablation, but also in conventional continuous wave laser treatment. The next topic is how the MicroPulse laser is used for DME in anti-VEGF era. These data of subgroup analysis in Residual group, which show that in the group with good visual acuity or mild macular edema, the visual gain is almost the same in the ranibizumab group as it is with laser monotherapy. The data showed that mild macular edema with good visual acuity can be treated with laser alone, with anti-VEGF therapy. These images have been obtained from ladies who appear to have focal macular edema, but present with diffused dye leakage. Visual acuity is still good, so this case is a good candidate for laser treatment. There is a microaneurysm located outside the fovea. In many cases with DME, diffused leakage is mixed with focal leakage from MA and is responsible for persistent macular edema. In such cases, we provide a combination treatment of subthreshold grid laser and direct photocoagulation for MA outside the macular area. Texture laser uses 577 nanometer wavelength, which is suitable for MA closure. So I use MicroPulse grid in the area inside the dotted line, and macular closure, MA closure was also performed outside the macular area. After combination therapy, macular edema decreased and anti-VEGF injection was not needed for this patient for more than 3 years after laser treatment. For severe macular edema, we first perform anti-VEGF injection and then apply MicroPulse laser to treat residual macular edema. This patient had severe diffuse macular edema with multiple microaneurysms. Initially, I treated her with 3 anti-VEGF injections, and macular edema was significantly reduced. Next, I applied laser treatment for the residual edema with MicroPulse grid and direct photocoagulation for MA. 3 months after ablation, macular edema did not recur and anti-VEGF was still not required. Here's another case. This patient had focal macular edema with a microaneurysm adjacent to the foveola. Fluorescent angiography showed a microaneurysm that is clearly responsible for cystoid edema. Thus, this case would not be amenable to anti-VEGF therapy. In such cases, we hesitate to apply laser application due to the risk of laser scar enlargement. However, I treated her with the texture laser using the MicroPulse mode with the least amount of energy that would elicit a change in color of the microaneurysm. 1 month after MicroPulse ablation, the microaneurysm is still patent, but cystoid macular edema was decreased. 1 year after treatment, macular edema was completely resolved and the lumen of the microaneurysms was completely closed. There was also a significant improvement in visual acuity, and the patient did not complain of scotoma. These are OCT images that were taken 1 month and 1 year after MicroPulse direct photocoagulation. Macroedema was completely resolved and the cystoid space was completely disappeared at 1 year. The photoreceptor ellipsoid zone and RPE are clearly visible, indicating that the integrity of the outer retinal layer was well preserved. This demonstrates that MicroPulse direct photocoagulation is a safer method compared to conventional direct photocoagulation with continuous wave laser. Here's another case. This patient had a persistent CSL with a leaking point adjacent to the foveola. In such case, conventional laser is contraindicated. Therefore, I would treat this case with MicroPulse laser ablation, which is likely to reconstruct the RPE cell layer. This patient was treated with subthreshold MicroPulse laser surrounding the leaking point, shown here with the red circle. Immediately after application of MicroPulse laser, the laser ablation site is invisible. Submacular fluid was almost completely gone 1 month after laser treatment. For CSR, in which the leaking point is located close to the foveal center, subthreshold MicroPulse laser is an excellent method to restore the integrity of the RPE cell layer as it targets damaged RPE cells without damaging adjacent tissue. In summary, MicroPulse laser is useful to control diabetic macular edema. The mechanism of action is presumed to be the upregulation of heat shock protein in RPE cells through sublethal laser ablation. 577 MicroPulse laser is useful for combination therapy using MicroPulse laser and direct photocoagulation. In advanced case, anti-VEGF treatment should be applied before MicroPulse laser treatment. Thank you.
Thank you very much. Are there any questions or comments? Anybody from the audience? Yes, we have a question. Can you hear okay now? Can you hear me? Yes, yes,
Yes.
Okay, 1 moment, please.
Thank you. Have you observed any photoreceptor migration over the areas of treatment?
Unfortunately, we had not done the animal experimental model, so we haven't. But your point is very good, so we will in the future do the experiment, study about that.
Any other comments or questions? Okay, well, thank you for your attendance. And Professor Okhoshi will be here for a few minutes. If you have any comments, you're welcome to come up and talk with her directly. Thank you.